Good afternoon, everybody. At the outset, I would like to thank Dr. Krishnaveni Madam and the other organizers for giving me opportunity to present this lecture today. So I will be discussing about respiratory diseases complicating pregnancy. Due to shortage of time, I will limit my talk to two diseases, that is asthma and tuberculosis in pregnancy. Great to see Jayanti Madam here, who is my teacher during MBBS days. Good afternoon, ma'am. So, as we all know, pregnancy alters respiratory physiology, leading to changes in lung volumes and respiratory functions. Respiratory conditions can complicate pregnancy and labor and increase the risk of preterm birth. Proper management of respiratory diseases is critical for maternal and fetal well-being. As we all know, this is the list of the common respiratory diseases that complicate pregnancy. Asthma is the most common chronic disease that complicates pregnancy, affecting about 10 to 15% of the population, and it may lead to preterm birth, low birth weight, and exacerbations during pregnancy. Pneumonias, both viral and bacterial, can be seen during pregnancies, and they may lead to maternal respiratory failure, sepsis, and preterm birth. Pulmonary embolism, the next talk, again happens in about 3 to 5 cases per 1,000. Increased risk of maternal mortality, fetal loss, and preterm birth. This disease can occur during pregnancy or postpartum. Tuberculosis, in a country like India, which has high TB prevalence, there is a high burden of pregnant TB cases, which can lead to both maternal and fetal morbidity and mortality. Upper respiratory tract infections, usually viral, are common during pregnancies, can exacerbated by the hormonal change in the respiratory system. They cause fatigue, poor sleep, and impact overall maternal health. Sleep apnea, often ignored, incidence is increased in obese pregnant patients. It can cause maternal hypertension and also lead to increased risk of preeclampsia. So now coming to the first disease we'll be discussing in detail, that is asthma in pregnancy. So what is asthma? Asthma is nothing but a chronic respiratory condition with variable airflow obstruction caused by airway inflammation and hyperresponsiveness. It is characterized by symptoms of cough, wheeze, shortness of breath, and chest tightness. These symptoms typically vary in intensity and over time. So asthma, as discussed earlier, is the most common chronic respiratory disease encountered during pregnancy and can occur in about 1 in 10 pregnant females. Nearly 40% of these females decrease or stop the medications during pregnancy due to the concerns of safety of the medications for their unborn child. 1 in 3 women with asthma experience an exacerbation during pregnancy. So what is the effect of pregnancy on asthma? Classically, it is said to follow the rule of thirds. That is, 1/3 of the patients with asthma, the asthma control remains unchanged. In 1/3 of the patients' asthma actually improves with pregnancy, and in about 1/3 of the patient, they have asthma deterioration and they lose their asthma control. The effect of pregnancy on asthma tends to be similar in successive pregnancies in the future. What are the potential risks of maternal asthma? As we know, it can have ill effects both on the maternal and the fetal health. On the maternal health, there can be maternal mortality, gestational hypertension, increased requirement of C-sections, hyperemesis, preeclampsia, vaginal hemorrhage, and placenta previa. When it comes to fetal health risks, they can have perinatal mortality, low birth weight, neonatal hypoxia, preterm birth, and congenital anomalies. So this was a very interesting study published in the ERJ, where they compared the outcomes in pregnant women with asthma who had an exacerbation during their pregnancy versus those who did not have an exacerbation during pregnancy. So as we can see in this graph, most adverse events such as congenital anomalies, preterm birth, low birth weight, and pregnancy-induced hypertension and preeclampsia were significantly higher in patients who had an exacerbation during their pregnancy. Even childhood pneumonia and childhood asthma, that is before the age of 5 years, was seen much more common in pregnant females, in children of pregnant females who had an exacerbation during their pregnancy. So coming to the diagnosis of bronchial asthma, it does not vary much between non-pregnant and pregnant females. The suspicion of asthma is based on the symptoms. Typically the symptoms, as discussed earlier, shortness of breath, wheeze, cough, and chest tightness. Typically these symptoms vary over time and intensity. They tend to be worse during night and early mornings, exacerbated by excessive laughing, exercise, by viral infections. and we can see they are usually triggered by exposure to some exercise or allergens. For the confirmation of diagnosis of asthma, we need to demonstrate variable expiratory airflow. This can be done by various methods, including PFT, PFER, improvement in lung function over a period of 4 weeks. However, among this chart, only one test, that is the bronchial provocation test, is contraindicated during pregnancy. As this statement was made all the way back in 1985 and still holds true till date. The care of a woman with asthma when she is pregnant differs little from that when she is not. So overall, coming to the management of asthma in pregnancy, the focus again should be on maintaining and achieving good asthma control. The management should mirror non-pregnant protocols, conduct early pregnancy review where you assess the control, check the adherence and the inhaler techniques, and provide an asthma action plan in case of an exacerbation of asthma. We need to identify the comorbidities which can worsen asthma and treat them. The common ones include allergic rhinitis, GERD, depression, anxiety, and OSA. Vaccination with COVID and flu vaccines is recommended during pregnancy to prevent the viral exacerbation of asthma.